So hi, everyone. Welcome back from the break. My name's Manali Kamdar, and it is my true pleasure to introduce my friend and colleague, Dr. Paolo Strati, as our keynote speaker. Paolo is an associate professor and the clinical lead for indolent lymphomas at the MD Anderson Cancer Center. He's an internationally recognized lymphoma expert whose work has significantly impacted our understanding and therapeutics around lymphoma. Beyond his impressive scholarship, and you can PubMed him, Paolo is known very much for his diligence, patience, thoughtfulness, and collaborative spirit. Every time I inherit a patient from Paolo, I have to be on my A game because patients always expect someone like Paolo, and then I walk in. So I am going to really look forward to his talk today on indolent lymphomas. He's going to give us some highlights, pearls, and then open it up after Dr. Duart's lecture for a Q&A with Dr. Chu. So I'm going to introduce Dr. Paolo Strati. Take it away.
Thank you, everybody. Thank you, Dr. Kamdar, for this extremely nice introduction. And just to be clear, my patients definitely prefer you over me. You're doing an amazing A+ job. So let me set up my timer so I'm on time. Good morning to everybody, and thank you to the organizers for having me here today. As you heard, my name is Paolo Strati, and I'm an associate professor in the Department of Lymphoma and Myeloma at MD Anderson Cancer Center in Houston, Texas. And I'm very excited to be here today to report some abstracts that I selected from ASH 2025 for indolent B-cell lymphomas, mainly follicular lymphoma, and then toward the end, we'll very briefly touch on marginal zone lymphoma. Oh, did I do something wrong? Yes. Okay. These are my disclosures. So it's always very hard when you are invited for this Best of Us session to be able to identify the best abstracts, particularly if you have just half an hour to go through them. So I decided to use as a criteria for presentation today abstracts that either are already impacting our clinical practice or that I feel will be clinically relevant in the very near future. So keeping this in mind, that's the agenda for today. We'll first talk about the new standard. We had an approval a couple of months ago in FL, which is the combination of epcoritamab and R-square. Then we'll talk about golcadomide and other ways that we're trying to get rid of the current standard, which is lenalidomide. Then we had to necessarily talk about surovatimig, which is the new kid on the block, and most likely will get an approval in the next couple of years. And then ASH this year was dominated by long-term data for CAR-T in FL, so I'll very briefly touch on that toward the end of the presentation. But let's start with the new standard. It's already there, so we need to know all the details. This was presented by Dr. Falke. It's a very large randomized phase 3 trial called the EPCOR FL1, comparing epcoritamab in combination with R-square as compared to R-square in patients with relapsed refractory follicular lymphoma. And actually, this presentation, same day, was published on Lancet, so you can look this up. As a reminder, epcoritamab is an anti-CD3, CD20 bispecific antibody, currently approved by the FDA as a single agent in third line and beyond for follicular lymphoma, whereas the combination of lenalidomide and rituximab, that we also tend to refer to as R-square, has been approved now for many years based on the AUGMENT trial in second line and beyond for relapsed refractory follicular lymphoma. As you all know, lenalidomide is an oral immunomodulatory agent with very pleiotropic effects on the immune microenvironment. So there's a strong preclinical rationale for combining R-square to EPCO, because of course, as EPCO is a T-cell engager, lenalidomide is supposed to potentially synergize with this agent. And there are also already out there safety and efficacy data, this combination. The phase 2 single arm of EPCOR square was actually published on Blood a few weeks before ASH, and clearly the combination was safe. So there was preclinical and clinical rationale for this very large randomized phase 3. In this trial, patients with relapsed refractory CD20 positive FL who had received at least one line of prior systemic treatment and who met GALF criteria were eligible. and they were randomized 1-to-1 to either EPCO plus R square or R square. I need to highlight that there was no placebo, differently from the InMind trial, which is another very large randomized phase 3 trial that, as I will discuss in a few slides, is also brought recently to an approval in second line for FL. The stratification factor for randomization in this trial were the timing from the prior treatment and the regional area where the trial was open. And I also need to emphasize the schema. So as a reminder, currently we give epcoritamab until progression or unacceptable toxicity, and it's an open discussion in the field because in third line and beyond for FL, there's another bispecific approved by the FDA called mosunetuzumab, which is a fixed duration. But in this case, actually, when EPCO was combined with R square, it was given overall for 12 cycles. So it was a fixed duration to kind of mirror what we do when we utilize R square alone based on augment trial data. And also the schedule was a little bit different. It mirrored the approval as a single agent until cycle 3, where EPCO is given weekly. But then from cycle 4 to cycle 12, it was only given on day 1 of a 28-day cycle. So overall, the schedule was more patient-friendly. The primary endpoints for this very large randomized phase 3 were progression-free survival and overall survival rate, overall response rate, and they both were presented at ASH. So overall, 488 patients were enrolled in this trial. 243 were randomized to EPCOR square and 245 to R square alone. And these are the baseline characteristics. And really, there are only mainly two things that I want to highlight. This was an older population. The median age was 61. As a reminder, FL is an indolent B-cell lymphoma mainly affecting older patients. The median age at time of diagnosis is actually above 70. So by the time they relapse, they may be significantly older than that. So we understand that in clinical trial, tends to be a younger population, but this is relatively close to real-world expectation. The other thing is the vast majority of patients on this trial had either intermediate or high FLIPI score. Now, what this may be striking, if this were a chemotherapy-based trial, it may not be relevant in an immunotherapy trial. So as a reminder, we currently have multiple prognosis scores in follicular lymphoma, FLIPI, FLIPI2, FLIPI F7, PRIMA-PI, you name it. But all of them, they've been trained and validated in patients who receive chemo. And there have been some data published that when we utilize those scores in patients who receive R square or immunotherapy overall, they actually don't stratify for progression-free survival. Though, as you will see, while I do love this trial and the outcomes, I'm not necessarily impressed with the fact that there was a high representation of high FLIPI, because again, these are not necessarily high-risk patients for immunotherapy. The other thing that I want to highlight from the baseline characteristics is this was mainly a second-line trial. So the median number of prior lines of systemic treatment was 1. And per study design, all of these patients had before an anti-CD20 and an alkylating agent. So kind of a classical population. All of us typically utilize as a frontline treatment for advanced stage and high tumor burden follicular lymphoma, chemoimmunotherapy like BR or CHOP, and then in second line, we look into things like R square. So we said, again, very representative of our real-world expectation for second line FL. Now, this is the primary endpoint, and this what, in my opinion, is very impressive. We very rarely see this in randomized trials in lymphoma. So the primary endpoint was met. As you can see, median progression-free survival after a median follow-up longer than 12 months was significantly longer for EPCOR square as compared to R square alone. Median PFS for EPCOR square was not achieved, whereas for R square was about 12 months. The hazard ratio was 0.2. Again, this is very unusual in lymphoma. And the risk reduction in terms of risk of progression or death was 79%. Of course, as the median follow-up is close to 12 to 15 months, that's where we have to concentrate as we look into this Kaplan-Meier curve. But the separation is mind-blowing, in my opinion. Also, this forest plot is quite mind-blowing. So the hazard ratio, pretty much for all the baseline characteristics, they do favor, and there's a lot of distance between the upper range of the 95% confidence interval and the 1 hazard ratio. They all favor EPCOR square. So definitely in all subgroups, this regimen, these were all pre-specified subgroups. EPCOR square was superior to R square. If you recall, I mentioned before that the co-primary endpoint was overall response rate. Also, this co-primary endpoint was met. Overall response rate with EPCOR square was 95%. 79% with R-squared alone. And this was mainly driven by CRs, which is very important in FL. So typically, particularly with immunotherapy, in FL, if your best response is a PR, it tends to be lost over time. Whereas CRs, and of course, deeper CRs, and you'll see in another abstract that some newer immunotherapies may help you to achieve a very deep CR, they tend to be durable. To this regard, median duration of response, including CR and PR, was, of course, significantly longer for EPCOR square as compared to R square. Same for duration of CR. But the next two curves are those where I think there should have been more emphasis during the presentation. I understand how, because of scientific reason, they were a little bit downplayed. So the first one is time to next treatment. So as you all know, patients with follicular lymphoma who relapse don't always require treatment. GALF criteria, which is the criteria that we follow to make a determination if patients do require treatment, were technically developed for previously untreated FL patients, but we all tend to utilize either GALF criteria or our personal eyeball GALF criteria to make the decision. So not every patient who relapses after R-square or EPCOR square may need additional treatment. So really what is clinically relevant for us and our patients more than PFS is going to be time to next treatment. And median time to next treatment here is almost flat for EPCOR square as compared to R-square alone. The other thing that I felt like was downplayed, everybody in this room, I see Dr. Kamdar also looking at this curve, can attest that in follicular lymphoma, I can't remember any trial where we saw a significant difference in overall survival over time. This was significant already, though we understand that with a longer follow-up, it may change. But median overall survival was significantly longer for EPCOR square as compared to R square. Of course, the separation, because it's too early and this is a slow-growing lymphoma, is not as impressive yet. But as I mentioned before, it's a very rare finding. And I'm looking forward to data with longer median follow-up from this trial. Everybody at the end of the presentation, though, argued, why should we give more treatment where these patients, by definition, are not really fighting for life? They're older, they're frail. Why should we give them more toxicity? Why don't we just give EPCOR square, R square alone, and then we add EPCOR in third line? So, of course, focusing on toxicity is very relevant for this trial. And EPCOR square was associated with a higher rate of neutropenia and a higher rate of infections as compared to R square. But the amount of dose reduction, dose delay, treatment discontinuation were comparable between the two arms. And the dose intensity and density with EPCOR square was the same as R square. So the take-home message is that even though, yes, there's a higher risk for neutropenia and infections, and so this is a more toxic regimen, at the end of the day, it's very highly manageable. And exposure to the regimen is going to be probably in clinical practice similar to R square, but we do require real-world experience for confirmation of these findings. When it comes to bispecifics, the adverse event of special interest are, of course, cytokine release syndrome or CRS and immune cell-associated neurotoxicity syndrome or ICANS. And the big question in this trial was by adding LAN to EPCO and engaging more and activating more T cells, are we going to see more CRS or maybe more durable CRS as compared when we use EPCO as a single agent? And the answer is no. The rates of CRS was about 40%, mainly grade 1, mainly during cycle 1, the same as we experienced when we utilize EPCO as a single agent. And the median duration of CRS was about 24 hours, which again is what we see with EPCO as a single agent. I think that this is very important to be aware of because, as you know, there are currently other randomized phase 3 trials trying to achieve the same goal with different bispecifics. The Celestimo trial is currently comparing Mosun-Lan to R square in a randomized fashion. And we do have safety data from the single arm phase 2. And by adding Mosun to LAN, we do see actually longer duration of CRS. So there's something that is currently favoring this combination, but formal data from Celestimo haven't been read out yet. So hopefully we'll hear more in next ASH. So as you heard, based on data from this trial, we can now use EPCOR square as a standard second line option in FL. And Dr. Falke made the consideration this is the new benchmark. There's one thing to keep in mind that exactly 1 year before, oh, it got stuck. Oh, that's stealing my momentum. Okay, exactly 1 year before, Dr. Sen presented at ASH another randomized phase 3 trial, the InMind trial, where the combination of tafasitamab, which is a monoclonal antibody targeting CD19 with R-square, as compared to R-square plus placebo. So these are more conservative and potentially more reliable trial, randomized phase 3, was superior. And so based on this, we also got an approval last year for TAF R-square in second line. So the big question now is, what do we do in second line? Do we give just R-square? Do we give TAF R-square? Do we give EPCOR square? And maybe biological factors or patient-related factors or logistics may make the decision for you. But our job is going to be much harder, most likely in 2028, because there are ongoing 3 large randomized phase 3 trial in the frontline setting, trying to move bispecifics to the frontline. The one that will read out earlier is EPCOR square in frontline. The primary endpoint is supposed to read in 2028. So we learned from the second line trial that EPCOR square is better than R square. And we know from relevance trial that R square is as good as chemo. So we can guess the EPCOR square is going to be better than chemo. So there's a high chance that this study will be positive and a high chance that by 2028, EPCOR square will be available in first line. If that happens, what do we do next? The big problem is that if you use lenalidomide in front line, what do you do in second line? And so that's the perfect segue for the next abstract, which is how do we get rid of len in second line? And there's a lot of interest in trying to achieve this goal, not only in expectation for the upcoming approval in frontline, but also because while we all love len for the efficacy that it can generate in FL patients, it's not easy to manage. It'll give you neutropenia, LFT elevation, fatigue, skin rash, and many times we have to do those reductions, and patients don't necessarily love it. So there's been an ongoing effort trying to generate new cell mods, new oral immunomodulatory agents that may be more effective but less toxic. And the one that seems to be closer to the finish line is golcadomide. So the way golcadomide works is very similar to len. It will target cereblon, which will favor the degradation of transcription factor, such as Icaros and Aiolos, which are relevant for not only anti-tumoral activity, but also for indirect immune activation. But the main difference between Golca and len is the site of cereblon, which is targeted. And allegedly, based on preclinical data, Golca is supposed to be much more potent as compared to len, 100% inhibition as compared to 20%. And I'll show you very briefly the preclinical data. As you can see here, there's a meaningful degradation in Icaros and Aiolos with Golca as compared to len, meaningful activation of T cells and NK cells with distribution in lymphoid tissue and spleen, so very promising in lymphoma. But I also want to emphasize that this may not seem relevant to FL because it's our preclinical analysis done in the LBCL cell lines, but Golca seems to be equally effective in GCB and ABC large B-cell lymphoma cell lines. So as a reminder, len seems to be working better in ABC large B-cell lymphoma, and that's where we tend to utilize like primary CNS lymphoma. But for FL, that's important because by definition, FL is a GCB lymphoma. So there's an expectation, and this has been confirmed by the trial, for very good activity in FL. So with this, I'll move to the abstract that was presented by Dr. Chavez this year. And I need to emphasize that what I will show you today, it's only the expansion cohort of this phase 1 trial, and particularly the combination expansion cohort. So there was initially the escalation cohort where we were able to identify 2 dose levels to further investigate. Golca at 0.2 milligrams or 0.4. And the way it's given in a 28-day cycle is 2 weeks on and 2 weeks off, whereas len is given usually 3 weeks on and 1 week off. And there were 2 expansion cohorts, monotherapy and combination. And again, what I'll show you today is the expansion cohort and combination. Overall, 60 patients were enrolled, 22 received 0.2, and 38 received 0.4. And what I want to highlight from this baseline characteristic table is that there was a good fraction of patients who had before len, because again, the overarching goal is to find an agent that may work in second line, understanding that most likely in the near future, len will be used in front line in FL. So of the 60 patients, only 1 patient has completed 2 years of Golca, which is the expected duration of this treatment. So these data are still early with a median follow-up of 13 months, but I think they're already informative. So the first piece of information that we have is that we don't see the typical adverse events of len. So we don't see skin rash, we don't see LFT elevation, The fatigue is much lower. With Len can be close to 90% the first couple of cycles. But the issue is neutropenia. So the clinical development of Golka has been definitely decelerated over the years, also in large B-cell lymphoma, because of the high rates of neutropenia. And that's why multiple dose levels have to be investigated. But the good news is that despite that, the rates of infection seems to be quite low, about 10%. What's quite striking is the activity, particularly for the 0.4. The response rate was close to 100%, with a CR rate close to 80%, even in patients who had Len before, even in patients who had bispecifics or CAR-T before, though these were not as many as the previously Len treated. And the duration of response seems to be more promising for the 0.4 as compared to the 0.2. And the preclinical data that I showed you before, where there's an expectation for Golka not only to have direct anti-tumoral activity, but also indirect through systemic immune activation, were confirmed also in patient-derived samples with significant increase in CD8 positive activated T cells and memory T cells within cycle 1. And also we had translational confirmation of meaningful degradation of Aiolos and Icaros within cycle 1 by immunohistochemistry. All this red-brown was Aiolos before starting treatment, and that's an on-treatment tissue biopsy during cycle 1, almost completely gone, so the target is being targeted properly. And also, as you will see here, this is multiplex immunofluorescence. So what you see here in purple on the top panel is lymphoma. Within one cycle, it was all gone, and the lymphoid tissue was mainly dominated by T cells. So the systemic immune activation with tumor infiltration is happening very early. So based on this very promising data, now we're moving toward a randomized phase 3 trial. That's the goal SIG4, where for patients with relapsed or refractory FL, the combination of Golka, of course, the 0.4, that seems to be the most promising dose and dose level with R, is being compared to investigator choice. Unfortunately, in this case, our chemo is also considered as an investigator choice option in second line. You could argue there are not either trial or real-world data supporting the recycling of chemo in second line for those who already had BR or CHOP in front line. And there's been a lot of criticism by investigators around this decision, but we'll see how the data will read out. Hopefully, most of patients will be randomized to R square, and it will be a cleaner design as in mind or EPCOR FL1.